All right, good morning, everyone. The honor to introduce Robert Frenck. Dr. Frenck has received his undergraduate degree at the University of California in San Diego, followed by his Doctor of Medicine degree from the University of Texas Health Science Center in Houston as part of the HBSB program. He completed his pediatric residency at the National Naval Medical Center in Bethesda, Maryland. After 3 years as a general pediatrician at the U.S. Naval Hospital in Japan, he entered pediatric infectious disease fellowship training at the University of Texas Health Science Center in Houston. After a 27-year career, he retired from the Navy and joined Cincinnati Children's Hospital in 2006. Dr. Frenck is board certified in both pediatrics and infectious disease. He maintains an active research portfolio and includes therapeutic and vaccine clinical trials with a special interest in enteric diseases. Dr. Frenck is professor of pediatrics at the Division of Infectious Diseases at Cincinnati Children's Hospital and is a director for their Center of Vaccine Research. Please help me give a warm virtual welcome to Dr. Frenck.
Thank you very much. And that, let's see, now I get back to where, where'd it go? Sharing my screen, there it is, okay. And so is that in full mode, Brian?
Yep, looks fantastic.
Okay, so good morning and welcome everybody. And I'm very sorry that I wasn't able to be there in person, but that Omicron had different plans. And so today what I'd like to do is to talk to you about the use of COVID-19 vaccines in children and adolescents. And that in the first place, if we can get the slides to move, that maybe, I'm not sure why they're not moving, Brian. They should be. Well, if worse comes to worse, I may need to get you up. There we go. My disclosures and then the objectives for the talk today. So first is to review the current epidemiology of COVID-19 and to discuss the COVID-19 vaccine clinical trials that are being conducted in children, and finally to evaluate the medical need to vaccinate children and adolescents against COVID. So in the first place, what I'd like to do is just go over a little bit about the virus itself. So this is the structure of the virus, and here in the inside is the genetic material with the little balls. There is the N protein or the nuclear capsid protein, and then in the envelope of the virus there is the envelope proteins and then the spike proteins. And if you look down here, this is a blow up of one of the spike proteins, and the spike protein is what the virus uses to attach to our body. And then within that there's a specific portion of the spike protein called the RBD, the receptor binding domain, and that is what attaches to our body, and that's what our antibodies are working against, that attacks that spot to prevent the virus to be able to attach to our body. So here's just a cartoon kind of giving an overview of the life cycle of COVID and then our natural immune response. So in the first place, a virus, a whole virion, would enter our cells. They then let go of their RNA, and they either make copies of their complete RNA and they make complete virions, or they may have incomplete production and just make the specific proteins here, making a spike protein that gets put in our cell. And this is what happens with the vaccines too, which I'll show you in a minute. So you're starting your immune response there. So then the complete virions are released into the extracellular fluid, and they're going to go look for other cells to invade. But when you then have the virus in the extracellular fluid, our immune system notes those as invaders and is trying to kill them off. And so we have a combination of our B cell, which then makes antibodies, and our T cells as a response. And so here, what happens is the virus is engulfed by what's called an antigen presenting cell, or an APC, which then stimulates both a T helper cell, the TH cell, and the CTL, the cytotoxic lymphocyte response. And so the combination of the B and the T cell response gives a very broad immune response against the virus and lyses the virus. So what happens with the vaccine is that you go through this exact same process, but you do it without having to be infected. So really what a vaccine is it simulates your being infected without you getting sick from the infection. So one of the things I want to do is step back and give a little bit of definitions here, because I think one of the problems we're having currently in the United States is a messaging problem, and that people are conflating infection and disease, but those are really very different terms. Infection means that you're able to detect the organism in your body. So if I do a PCR, if I stick a swab up your nose and I get the PCR positive, a rapid antigen positive, or if I would do a culture and it's positive, that's an infection. I'm able to find the organism in your body. But the other thing is disease. And so disease is infection with symptoms. And then you have a spectrum of illness. And for COVID, it's about the widest spectrum of illness that I can think of, because you can go from asymptomatic or a very mild infection all the way to death. And so I would love to do with the vaccine to prevent all infections, to prevent all disease, but I'm really interested in preventing the moderate to severe disease, because that's what's keeping you out of the hospital. And that's where I think we're losing our message. And hopefully what I'll show you in the next few slides, and that if these next few slides, you pay attention to those and you fall asleep, it's okay, because I think I've gotten my message across in the next couple of slides. So here what we're looking at is the incidence of COVID-19 by age in the United States. The vertical axis here is showing the incidence per 100,000, and the horizontal axis is the time starting from April of 2020 up to January of 2022. And then the different curves are represented by the different age groups here. What you can see is in April of 2020, when we first started having statistics in the United States, the highest incidence group was in 75 years of age and above. Currently, that's the lowest incidence group. The highest incidence group we have now are in children and young adults. And so this really is showing how the epidemiology of the infection or the pandemic has changed from one of the older people. It's still bad in older people, but now our most predominant group is in younger adults and children. The other thing you see in this slide is the 3 waves that we've had so far. So here is around November, December, the holidays of 2020. Then the disease went down. We were hoping everything went away. And here's the Delta surge that we saw just as kids are going back to school. That started to go away. And here's the Omicron surge. Unfortunately, as you can see, is that the number of cases of Omicron far has surpassed either that surge last holiday period or the Delta. This slide is then looking at just pediatrics as far as the number of infections. Again, it's not hospitalizations or death, it's infections. But again, looking then is the number of cases here and over time. And again, this data very much parallels what we saw in the adults, as far as that you're getting a peak around the last holiday season in 2020. Here's your Delta, and then here's Omicron. And so what we're seeing, as far as now, we've had more cases per week in children than ever before. So this slide is looking at the COVID-19 associated cases, so infections in the United States by vaccine status. And so the horizontal axis here, I took these slides from the CDC. They actually had a typographical error. They put 2022, this is 2021 in here. Hopefully they're not foreseeing the future. So this is 2021. This is the incidence of cases, and this is time. And this curve here is the vaccinated, and this is the unvaccinated. So what you're seeing is that here, around the time of Delta, and all the data are going to lag a little bit because it just takes some time to accumulate. But around Delta, we did see a blip in the number of infections. But look at the change between the uninfected and the infected. Where the huge blip the unvaccinated and the vaccinated. The huge blip was in the unvaccinated. Even more importantly, this is looking at hospitalizations in the US between January and November of last year. Again, the rate per 100,000 and time. The green curve here is the vaccinated, and the blue curve is the unvaccinated. What you see is that the curve for the vaccinated is basically flat for hospitalizations, and that the rate of hospitalizations in the unvaccinated is what has climbed. And so this is why when people say this now is a pandemic of the unvaccinated, this is why they're saying that. This is then looking at deaths in the US by vaccine status. So again, the CDC made a mistake as far as the year. This is 2021. But here is the vaccinated group and unvaccinated group. And I think, again, it's pretty easy to see that the fully vaccinated group, their curve is flat versus the big spike that's happened with the unvaccinated. Now, this is with the Delta wave. I just saw some data the other day that the deaths lag behind infections by about 2 to 3 weeks. That the fear is that we may see an additional 200 to 300,000 deaths just from the Omicron surge alone. So then if you put all the data together and say this is through 2021, so this is through Delta, it may change a little bit with Omicron. I don't think it's going to. If anything, I think the way it's going to change is for the worse for the unvaccinated. But here, if you look in October 21, if you look at unvaccinated versus fully vaccinated, so fully vaccinated means 2 doses of Moderna, 2 doses of Pfizer, or 1 dose of the Johnson & Johnson, that the unvaccinated people had a 5 times increased risk of testing positive for COVID, so a 5 times increased risk of being infected, and 14 times increased risk of dying from the virus compared to vaccinated. If you then look at unvaccinated versus fully vaccinated and boosted, the numbers even get worse, so that you have a 10 times increase of being testing positive for COVID and a 20 times increased risk of dying from the virus. So then moving in generalities to specifics in children, why do we need COVID-19 vaccines in children? So this is as of 10 days ago, so in COVID time, ancient news, but you basically need to update your slides every day if you're going to try to get the most current. But as of last week, we had almost 8 million children infected in the United States. That has resulted in 29,220 children being hospitalized for COVID, not hospitalized and having COVID, hospitalized for COVID. And then 6,400 have MIS-C, the multi-inflammatory syndrome of children. And 62% of those have been Hispanic and Black. And that's important because the Hispanic and Black population only make up about 20% of the population in the United States. So there's a very large overrepresentation of MIS-C in the Hispanic and Black population. We've also had 735 children die from this infection. So people could say, well, we've had 800,000 people total that have died in the United States and only 735 children. That's true. But these 735 children, most of them have been previously healthy children, no underlying conditions. And so it's quite scary. The other thing, though, is that the pandemic has not only taken a medical toll, it's taken a toll on children's health and mental and emotional health. We know that the emergency room visits for psychiatric illnesses have increased dramatically. Suicide attempts have increased dramatically. The social well-being has been bad. Educational experience has been horrible. Is that at least in Ohio, we had data to show that kids not only were not staying flat on their education, that they were dropping points on the standardized tests. So this has been a very troubling pandemic for many reasons. And that, one of the things too is it's really exposed the underprivileged and that how they even have a worse time, because there's about 10 to 15% of the children in the United States have no access to computers at home. So if you're trying to do distance learning and they have no computers, it's not going to be working very well. So this slide is looking at a model the person put together early in the pandemic, trying to predict what pediatric hospitalizations would look like based on the infection rate. So with her numbers right now, we're at about 10%. We're about 8 million, but this is 7.3 million. And what she was saying then is that we'd end up having around 19,000 hospitalizations or ICU admissions. And in fact, as I showed you before, we're over 29,000. So her model is about 50% underrepresented. But if you just continue with her model and say, if we get to 25% of children, her model will predict 50,000. And if she's again 50% underestimated, that would be 75,000 children in the United States that would be hospitalized for COVID. And many of those will end up in the ICU. For children and adolescents that end up hospitalized, about 1/3 end up into the ICU. So about 18 months ago now, is the NIH put together a bioethics panel to ask, is it okay to start doing trials for COVID-19 vaccines in children? And this was done because we now had already had a number of months of testing in adults and wanted to say, is it okay to move on to children? And that the bioethics panel said, yes, there is sufficient data in adults to justify initiating trials now for children. And what they said then is trials should first enroll small numbers of older children with no underlying health conditions, and then have subsequent trials de-escalating. So if you're having 16 to 17, 12 to 15, 6 to 12, and on down. And that's actually what ended up happening, was done. And then you have the trials need to ensure that participants reflect the geographic and demographic diversity of populations affected by the pandemic. And so what you're saying there is we want to make sure that the people in the trials really represent the population. And we tried very hard to do that. And most of our trials came out pretty close, especially the first trials in the adults came out almost identical for the population of the United States, which is really important to be able to provide that generalizable data for the US. And then this is an op-ed that came out in JAMA Peds the middle part of last year, saying what they thought would be the criteria to consider for requiring vaccination. So first, whether the NIH was saying, should you test vaccines in children? They said yes. And this op-ed is in saying, okay, now if we have vaccines, when should we use them in kids? And so that first they were saying that the experience indicates the vaccine safe and immunogenic, which I'll hopefully show you that you'll agree that that's true, that the vaccine is cost effective from a societal perspective, which we've shown to be true. The vaccine should increase safety in the school environment, which actually we have found that the vaccine will decrease transmission. The vaccine is effective in at least some set of the population, which we know it's been very effective in a large subset of the population. And as I say, that the vaccine reduces person-to-person transmission, which we think it does, and that it's acceptable to the medical community, and that the administrative burdens of delivery tracking are reasonable. At first, administration of the vaccine was a bit difficult because of needing to have in the ultra cold, but now we have further stability testing of where we can, we've seen that we can keep the vaccine in a refrigerator for even a week or more. So that really allows us to be able to position vaccines in the pediatrician's office. And then the burden of adherence is reasonable for the parent caregiver. And I have a slide later on to show you is that if a child gets their first dose of vaccine, close to 90% get the second dose of vaccine. So I think that shows that the burden of adherence is reasonable. So then this slide is looking at pediatric hospitalizations in the United States in COVID versus selected viral illnesses for which we routinely vaccinate. And the argument here is that if we think it's important and we know it's important to vaccinate against these other viruses, how could it not be important to vaccinate against COVID? So this first column here is the different viruses: COVID, influenza, varicella, rotavirus, rubella, hepatitis A. Many people have never seen cases of rubella or hepatitis A, and that's good. These are good problems. But these, if you look then in the second column is the hospitalizations, you can see that rotavirus far exceeded hospitalizations for any of the other illnesses, but otherwise COVID was right in the mix as far as for the number of hospitalizations per 100,000. And this is before we've had some of the spikes with Omicron. And then the deaths far exceeded any of these other diseases for which we routinely vaccinate. So to me, I think this in itself shows why we need to vaccinate against COVID. Just for the direct effect alone. Don't even talk about the indirect effect by immunizing kids and preventing transmission from person to person. This is just the direct effect for the kids. One of the things too, then people said, well, it doesn't make sense, the vaccines aren't effective enough, is that the COVID-19 vaccines aren't effective enough. And so I took a couple of the other, or three other vaccines that we routinely use in pediatrics to show you that not all our vaccines are 100% effective, but they're still good. So for influenza, depending on the age group, your effectiveness against all infections ranges maybe in one study for 65-year-olds as low as 16%, but usually around the 60% preventing all infections. But a more important thing is that it has about a 60% decrease in hospitalizations. And so that's the thing, again, with flu, we're really trying to do is we're trying to prevent the hospitalization, we're trying to prevent the deaths. If you look at pertussis, so for the DTaP, for the primary series for the younger children, the pertussis vaccine is 98% effective for 1 year, but by 5 years, it's only 71% protective. And if you look at Tdap, where we're then using a smaller amount of pertussis protein, that the vaccine efficacy at 1 year is only 73%, and it's miserable by 4 years. It's only 34%. And rotavirus, the main thing is that people are looking at it is it had a 98% decrease in hospitalization, which is tremendous. I can tell you in the days Dr. Lopriato and I were interns together at Bethesda, is that every winter we had our unit full of kids that were dehydrated from rotavirus. We don't see that anymore. But if you look at all infections, it's only 74% protective against all infections. So I would argue that the COVID vaccines actually surpass the data for all of these vaccines, which we know are very important to use. So this slide and the next three slides, I'm just going to go over the three platforms that were tested in the United States. The vast majority of the rest of the talk will talk about the mRNA vaccines because that's the only data I have for children yet, but I want you to know about the other platforms because they're important. This is the first platform is the protein protein platform, and it's one that's the more common or traditional kind of platform of where we've made most. And here what you're doing is that you're having the protein-based vaccine. You're taking the specific viral protein or bacterial protein and that you want, and then you're going to elicit an appropriate T and B cell immune response. So for the protein-based vaccine has been tested in the United States as a Novovax vaccine. It's gone through a phase 3 clinical trial and has been submitted to the FDA for consideration for EUA. I don't know the status of it, but it has been submitted. They found that they use the spike protein itself. So whereas the adenoviral and the mRNA use the gene of the spike protein, the Novavax used the spike protein itself. This spike protein by itself was not very immunogenic, and so they had to add what's called an adjuvant, which stimulates the immune response. They used an adjuvant called MF59, which is squalene, and they found then that they got an excellent immune response. So this is a one type of vaccine that's available. I don't know if it will come to authorization or license here in the United States, but testing has been done. It showed it was very safe, it was very immunogenic, and it was protective. This then is looking at the adenoviral vectored vaccines. And so what you're doing with adenovirus, you're taking a replication incompetent adenovirus, and that so that if it gets into you, it won't replicate. For the Oxford or for the AstraZeneca, they used a chimp adenovirus because we don't have antibodies against chimp adenovirus, so that would decrease the risk that the vaccine is degraded before it ever gets into the cell. For the Johnson & Johnson, it used a human attenuated adenovirus. But what you're doing basically is that you're using the adenovirus as a way to transmit or bring the spike protein gene into our cell. And then what happens is the adenovirus lets go of the spike protein gene, and then our own cellular machinery translates, using the tRNA, it translates the mRNA into the spike protein, puts the spike protein on the surface of the cell. And then down here is basically the same things I was showing you in that slide as far as for natural infection. You stimulate the B cells, you stimulate the T cells, you have the antigen presenting cells. So you have a very broad immune response. And so for both the adenoviral vectored vaccines and for the mRNA vaccines, you have a predominantly Th1 response, which is very important because that's a pro-inflammatory response. One of the concerns that people had is that you would get what's called enhanced disease, that you vaccinate kids and then they get infected, that they would actually get worse disease. That was what we saw in an RSV vaccine back in the 1960s. We found that was due to a predominantly Th2 response. We did not think that there was going to be any enhanced disease. And actually, I can tell you, we have not seen any enhanced disease at all in children. So then moving on to the mRNA vaccines, the step one here is what you're doing is you're taking the gene of interest, and then you have to put a lipid nanoparticle around that. If you just have naked mRNA, you have extracellular RNases that degrade your mRNA. And we have that because we don't want mRNA floating around in our system. We want it eaten up as soon as it's done its job. So one of the things people have said is that they don't want to get vaccinated because the mRNA is floating around in our system and it's going to cause problems later on. It's just not true. The mRNA is degraded within 1 to 2 days after vaccination. So there is no mRNA that's floating around. This is what we do normally when we have our own cell replication. We have RNases that chew up the mRNA after they've done their translation of the protein. So that just like we're talking about with the adenoviral vectored vaccines, the mRNA is translated into a protein using the ribosomes, which then put the protein on the surface and antibody response or T cell response, and that then also having a B and T cell. So then moving on to that is specific trials we had in children. So what I'm going to show you is that all the data that I could find that's been in the United States, you're going to see that the vast majority of this is on the BNT162b2 vaccine or the Pfizer vaccine, but that's really what's been published. That's what's available. And so for the adolescent vaccine, we immunized 2,260 adolescents 12 to 15 years of age, and they were randomized 1-to-1 to vaccine to placebo. And they got 2 doses 3 weeks apart of the 30 microgram dose. The 30 microgram dose is the dose that we used in adults. We then collected blood at baseline, so before dose 1 and a month after the second dose. And that way we could see what our peak immune response was. We collected local and systemic reactogenicity or side effects for 7 days after each dose. And then we had serious adverse events and unsolicited adverse events. So basically, we said, did you have any other adverse event we didn't ask you about? We collected that for 6 months after dose 1. And then we looked at the immunogenicity, how high of the immune response that happened to safety, and then efficacy if there was. And these studies were not powered for efficacy. They are powered for what's called immunobridging. And what that means is that you're looking at the immune response in one group and comparing it to the immune response in another group for which you have efficacy. And so if the immune response in the one group is comparable to the immune response in the other, then the extrapolation is that the efficacy is the same between the two groups. And so that's really what these were powered for, is immunocomparability, immunobridging. So this slide is then looking at the local reactogenicity after vaccination. This is dose 1 and dose 2. Across the top are the different adverse events we're looking at: redness, swelling, and pain, and the percentage of participants. The first column is the 12 to 15-year-olds. The next column is the 16 to 25-year-olds with a vaccine. And then the two columns after that are 12 to 15-year-olds and 16 to 25-year-olds that had placebo. And so what you can see is that by far and away, the most common local side effect or adverse event was pain. It was basically equivalent between the 12 and 15-year-olds and 16 to 25-year-olds, and it was higher than the placebos. But one of the things I think is important to see, and you're looking in the next slides even more so, is that even in the placebo, people were complaining of pain. So that this is one of the reasons you really need placebo when you have subjective kind of complaints, because it's really hard to judge otherwise. So if you have redness or you have swelling, those are objective and you can measure those, and then you could argue you don't need a placebo as much. But for things subjective like pain, you really need a placebo. This is then looking at the systemic adverse events or side effects that happened after dose 1. Here again is your percentage of participants and your different side effects you're looking at, set up the same way as the last slide as far as the vaccine and the 12 to 15-year-old vaccine and 16 to 25-year-olds, and then 2 placebo groups. So what you can see is that the most common were fatigue and headache, and that it was basically identical between the 12 to 15-year-old and 16 to 25-year-old. But that one of the things, again, it shows here is that for the placebo is that there's almost as many placebo recipients that are complaining of fatigue and headache as vaccine recipients. And to me, what that just shows, as far as that people may have just ignored their fatigue or headache otherwise, but you're asking them questions, say, well, I am in a vaccine trial. Yeah, I don't feel quite right. And people report things. And so when people say, why do you need a placebo? This is one of the reasons why you need a placebo, to really get a good idea of what the reactogenicity is in the vaccine or the study product recipients. So this is for dose 2, same setup. And what you're seeing here is that, again, the likelihood of an adverse event is the same in the 12 to 15-year-olds for 16 to 25-year-olds, and that the frequency of the adverse event does increase a little bit with the second dose. We've seen that with the Moderna and Pfizer. Interesting, for the AstraZeneca, for whatever reason, the second dose had less side effects than the first dose. For the adenoviral vector, it was the opposite of the mRNA. So this slide is then looking at the geometric mean ratio of the neutralizing titers. And so the neutralizing titer is that's a term that we're using as far as to say how much of the virus is neutralized, is killed. And so what you do to look at this is that you have virus that you put on a line of cells, and you see how many plaques, how many holes you have in your assay. And those plaques are where virus have been able to grow. And then what you do is that you have another assay where you do the same thing, but instead of just having virus, you have dilutions of serum, and that the amount of times that you can dilute the serum and still get 50% reduction in the ability of the virus to be able to cause infection, that's your neutralizing titer. And so for the 12 to 15-year-olds, the neutralizing titer was 1,239 compared to 705 in the 16 to 25-year-olds. So the goal of the study was to show that the vaccine was at least as good as creating an immune response in 12 to 15-year-olds, at least as it was in 16 to 25-year-olds. What we actually found it was 1.76 times higher immune response in the younger group than the 16 to 25-year-olds. So it not only met non-inferiority, the immune response in the 12 to 15-year-olds actually was superior. This slide is then looking at efficacy. As I mentioned, we were not powering the study for efficacy, but unfortunately there was sufficient amount of COVID in the community that even with 2,200 kids, we were able to show efficacy. And that if you look at, we looked at it two different ways. One is that if you didn't have evidence of prior infection with COVID, or if you did have prior evidence of COVID. So what happened at baseline, we did a swab. We didn't exclude them from being in the study, but we had that data, and then we looked at it and said, okay, if you had evidence of prior, and also antibody levels. So if you had evidence of prior infection before vaccination, did that affect your likelihood of being protected? And what we found is that in neither group did we have any cases in the vaccine group, whereas that we had 16 or 18 in the placebo group, which come out statistically to 100% protection. What I would say is that the protection of the vaccine, the efficacy of the vaccine is the same in 12 to 15 year olds. I don't think it's appropriate to say 100% protection because it's just not going to be true. It's just these are small numbers, but I would say that the efficacy is equivalent as what we saw in adults. And just to remind people, this is what the data look like for the adult trial for the Pfizer vaccine. Is that here again are looking at the cumulative incidence, and that over time, here's where they got dose 1, here's where they got dose 2. And this curve here is the number of cases in placebo versus the cases in the vaccine. So you see that there was an uptick in that first 14 days, but after that, the cases in the vaccine group were almost flat. If you then look at this insert here, this is looking at a blow up of the number of cases in the days after the first dose. And you can see by around day 12 to 14, you're starting to see separation between the placebo and the vaccine recipient. And this then translated to an overall vaccine efficacy of 94.6%, 95%, so phenomenal. Then moving on to the teen Cove study, so the Mrna Vaccine study from the 12 to 18-year-old. There were 3,732 participants. They did things slightly differently. They had a 2-to-1 randomization of 2 vaccine recipients to 1 placebo recipient. They gave the 100 microgram dose, which is the same dose adults received, and theirs is 28 days apart. So the Pfizer vaccine is 2 doses, 21 days apart. The Moderna's 2 doses, 28 days apart. Otherwise, the way that they did things is basically identical to the Pfizer. They got the nasal swab and serology at baseline, and then they got another blood draw 28 days after the second vaccine, and they collected the local and systemic adverse events, just like I told you with the Pfizer. So here we're looking at the local adverse events in the first and second dose of getting the Moderna or the mRNA 1273 vaccine. So these first 2 columns are the placebo. These next 2 columns are the vaccines for dose 1 and dose 2. And so what you can see, very similar to what we saw with Pfizer, is that the most common is pain, and that the first and second dose have about the same frequency. Here then we're looking at the systemic adverse events after the first and second dose of the mRNA 1273, the Moderna vaccine. So set up the same way. The first 2 columns are placebo. The next 2 columns are vaccines, and vaccine 1 and vaccine 2. So what you can see is that headache and fatigue and myalgia are the most common side effects, the exact same things that we're seeing with the Pfizer vaccine. And very similarly, and it's just a little bit easier to see here because they're all on one slide, is that the frequency of headaches, again, were very similar between the placebo and the dose 1, and that when you go from dose 1 to dose 2, you did have an increase in frequency. So here's the serological response in the adolescents compared to the young adults. So they compared the 12 to 17-year-olds to 18 to 25-year-olds. So basically the same thing, slightly different age groups, but basically the same thing that Pfizer did. And that what they found is that the immune response was the same. And that's all we really were looking for, is to get the equivalent immune response. So we didn't see a superior one with the Moderna, but we saw equivalent. Equivalent is fine. And then here's looking at efficacy depending on various markers of the efficacy. And that and so on the whole, though, is that the efficacy came out around 92%. These lower numbers here were having very much more strict criteria for COVID, and so that it's a little bit unfair to look at that, but they were just trying to present all the data. I would focus up on here because this is really the per protocol is around 92%. So again, I would say that the efficacy, even though it wasn't powered for efficacy, was equivalent to adults. And then again, just for historical, this is the data from the original mRNA 1273, the Moderna adult trial, and that here you're looking at the cases in the placebo versus the vaccine. This cut point here is where they started to measure efficacy, which is 14 days after the second dose. And that data ends up being a 94% efficacy. So again, just phenomenal about how well it worked. So now we've gone from the 12 and above. And so then the next step was to look at vaccines in younger children. And so I'm the principal investigator at Cincinnati Children's for a grant with the NIH, what's called the VTU, the Vaccine Treatment Evaluation Unit. And there's 9 sites in the country, and most of the sites have a pediatric infectious disease physician involved. And so the NIH asked the Peds ID doc at each of the sites to get together and to give Dr. Erbelding, who's the head of DMID, one of the sections at NIH, our thoughts about how you would design pediatric trials for kids under 12. And so we thought is to give 3 age groups, 6 to less than 12, then down to 2 to 6 year olds, and infant to 2 years. So really kind of following the recommendations of the NIH Bioethics Committee. And so what we thought to do is then to give, in the first place, the 6 to 12 year olds a half dose of what the adults were given and see how that does. If they do okay, then to go to a full dose in the 6 to 12 year olds. At the same time, you're doing a half dose in the 2 to 6 year olds, and then going down in the 2 to less than 6 months of age. And so that the reason that we're doing it this way is that you can actually speed it up. The other way that it sometimes would be done, or oftentimes would be done, you do the half dose and then the full dose in this group, and then you go over here and do the half dose and full dose, and then the quarter, half, full dose. That delays things. We thought with the pandemic, and with the safety we knew about the vaccine in adults, we thought that it was appropriate to speed things up a little bit and do this kind of mechanism. So whether the Pfizer and Moderna took our recommendations, or they came up with simultaneously the same recommendations, I can't tell you, but the designs that both Pfizer and Moderna used were very similar to those recommendations I just showed you. So Pfizer, they have 3 age groups, 5 to 11, 2 to less than 5 years of age, and 6 months to less than 24 months or less than 2 years of age. And so in the first part, we had a dose finding, which is an open label looking at 10, 20, and 30 micrograms. To remind you, 30 micrograms is what was used in adults and for the adolescents. And then in part 2, it was a placebo-controlled expanded cohort randomizing 2 to 1 vaccine to placebo using the optimal dose from phase 1 or part 1. And then around 2,250 kids in the 5 to 11 and 11 to 25 in each of the other 2 younger groups. And then we're measuring the same thing as looking at the adolescents, the safety and tolerability, the immunobridging, and efficacy if there were sufficient cases. There were 2,285 children randomized 2 to 1 for the 5-year-olds that received the 10 micrograms. So what we found is that the 10 microgram dose provided equivalent immune response as the 30 micrograms in 12 to 15-year-olds. So we went with, to 16 to 25-year-olds. So that's why we went with the 10 microgram dose, because it gave this equivalent immune response, and it actually had a better safety profile, less adverse events. So for the children 5 to 11, their adverse event profile was good and mirrored the adolescent and the adult data. And as I mentioned, we used the 10 micrograms because it's equivalent to 30 micrograms. We found 3 cases of COVID-19 in the vaccine recipients versus 16 in the placebo, which resulted in a vaccine efficacy of 91%. And there were no cases of severe COVID or MIS-C reported. So again, this study was designed for immunobridging, but we have, in all of the studies, unfortunately, we had so much COVID in the community, even with the smaller numbers, we were able to show efficacy. So these next slides are just going over the same thing as I showed you with the adolescents, but now looking at 5 to 11-year-olds. This is looking at the local reactogenicity, and just like we saw with the adolescents, is pain is the most common for both the first and second dose. And then we're looking here at the systemic adverse events. And so we looked for the same events and we saw the same things, but actually what we saw was that the frequency was lower in the 5 to 11-year-olds than it was in the 12 to 15-year-olds or 16 to 25-year-olds. So that we got the same immune response and we had a better safety profile. And so that that's why we're happy with that 10 microgram dose in the 5 to 11-year-olds. This is then looking at the geometric mean ratio of the neutralizing titer, comparing the 5 to 11 to 16 to 25, again, with the idea of this immunobridging. What we found was that the geometric mean ratio is 1.04. So basically identical between the 5 to 11-year-olds and 16 to 25-year-olds. And so if we just use this as the immunobridging, we would make the assumption that the immune response, the efficacy was the same in the two groups. We actually do have some data, as I showed you there, to show that that was true. So I think in the end, what you can say is that for the 5 and above, where we have 5 years of age and above, where we have the data, the efficacy of the vaccine has proven really equivalent, regardless of the age tested. And then for the kid Cove study, this is really right now, I don't have any data other than what's listed about the protocol in clinicaltrials.gov because they haven't published anything yet. But they have 3 age groups, 6 to less than 12, 2 to less than 6, and then 6 months to less than 2. They also did a part 1, the dose finding. They did 25, 50, and 100 micrograms. And as I mentioned before, 100 micrograms is what was used in the adult trials. Moderna has changed, and now for your booster dose, it's a 50 microgram dose for the booster instead of the 100 microgram for the booster. For the part 2, then they're going to use a placebo-controlled expanded arm. I can just tell you, I know because we're doing the trials, is that for the 6 to 12-year-olds, we used 50 micrograms, and same thing for the 2 to less than 6-year-old, and then for the younger kids, we used 25 micrograms. But I don't have data yet because they have not collated and released that yet. And then the outcome measure, the same thing of looking at the safety, tolerability, the immunobridging, and efficacy if they're sufficient. So then now all these other things we've been talking about is vaccine efficacy. And so efficacy means in a clinical trial where you're very tightly controlling what happens when people come in, when they get their vaccine, when you test for the virus and blood immune response and everything. An effectiveness trial is basically real world setting. And so that people are supposed to get the vaccine 21 days apart, but we know that some people really come in, they get it 28 days apart, some people get it 2 months apart, some get it a little bit short. And so it's looking at what happens in a real world setting. So this first study was of almost 4,000 healthcare personnel, which are first responders. And they had almost 3,200 that received 1 dose of the vaccine and 2,700 received 2 doses. It was a split 2 to 1 Pfizer, Moderna. That's just the vaccines they had available. And then they self-swabbed for COVID weekly. Of the people that were vaccinated, 204 personnel developed COVID, and 5 of those were vaccinated. So 199 were unvaccinated, 5 were vaccinated, which resulted in a vaccine effectiveness of 91%, which mirrors the efficacy. And this is really tremendous because a lot of times effectiveness trials don't come near close to the efficacy. The other thing that was very important in this study, they found the viral load in vaccinated people was 40% lower than unvaccinated. So to me, what that translates to is that the likelihood you're going to transmit, even if you're infected and you're vaccinated, is a lot less. This is another vaccine effectiveness study where they used from England as an immunization database, and that they looked at people that had been vaccinated with 1 or 2 doses. In England, what they're doing is that every person who has COVID, they're collecting their isolate and genome, sequencing it so that they know exactly what variant of the virus is circulating. And so for Pfizer, so the 2 vaccines that were tested in Great Britain, or that were administered in Great Britain, were Pfizer and the AZ vaccine, AstraZeneca. And so what they found for the 2 doses of the Pfizer vaccine was 93.7% effective against alpha and 88% effective against delta. This is against all infections. And then AZ was 74.5% and 67%. So a little bit lower than Pfizer, but still good. Just as a background, as far as when we went into this, we were hoping that we would have one vaccine that would be at least 50% effective against preventing infection. We actually have 3 vaccines available in the United States, all of them in excess of 75%, and then 2 of them are in excess of 90% against infections, and over 95% effective against severe disease. So to me, this is not only hitting a home run, it's a grand slam in the bottom of the 9th inning in the 7th game of the World Series to have a walk-off. I mean, is how phenomenal these vaccines have performed. So this is some data that was just recently published in the MMWR, looking at the vaccine effectiveness of the BNT162b2 vaccine in the United States. And so that they're looking at people that are either unvaccinated, partially vaccinated, which means it's less than 13 days after their second dose. So if they've had 1 dose and they haven't had the second dose, fully vaccinated, it's 14 days after the second dose. What they found is their vaccine efficacy was somewhere between 92 and 94%. Again, mirrors what we had in the efficacy trials, which is tremendous. And then this, again, was just recently published in the New England Journal of Medicine, of looking at the effectiveness of vaccines against critical COVID in adolescents. And this is a case control and test negative design. So basically, test negative design means that you're testing people that have similar symptoms, but they don't end up having COVID, so that's a test negative. And so then they were looking at the vaccine effectiveness resulting in hospitalization, ICU admission, or life support intervention. And they had active surveillance of 12 to 18-year-olds in 31 hospitals in 21 states. This study was conducted between May and October of last year. They had 445 cases and 777 controls. There were 17 case patients and 282 controls that had been fully vaccinated. So you can see the fully vaccinated was much higher in the controls, and that 96% of the hospitalized and 99% receiving life support were not fully vaccinated. So basically, translated the other way, this is almost all a problem of unvaccinated. If you then look at on the case patients, 180 or 40% were admitted to the ICU. So again, what I was saying before is that if adolescents are admitted, they have a high likelihood of ending up in the ICU. In this report, 40%, and 29% of those admitted to the hospital required life support. And only 2 of these people had been fully vaccinated. And so then in summary, if you're looking at the effectiveness of the vaccine against hospitalization, it was 94%. Against ICU admission, it was 98%. Against requiring life support was 98%. And against death was 100%. So to me, this is again, the money slide here. This shows you how effective this vaccine is against preventing the very serious infections that we really want to prevent. So then moving on a little bit about the safety of the vaccine. This is looking at myocarditis. And one of the things that we do is that we have safety as any part of our clinical trial, our efficacy trials. But then even after a vaccine has completed clinical trials, we continue to collect safety data. And the CDC has what's called VAERS, the Vaccine Adverse Event Reporting System. And so the CDC estimates that there was about 4 per 100,000 doses administered in 12 to 15-year-olds following a second dose of mRNA resulted in myocarditis. There was a database review from Canada that they came out with very similar numbers with the Pfizer vaccine at 4 per 100,000, the mRNA 1273, and the Moderna vaccine 26 per 100,000. So again, very rare. What the Canada data showed very same as the CDC is that the cases occurred, almost 80% occurred within 7 days of vaccine administration. About 80% were in males, and about 70% was after the second dose. But then what about looking at, again, another study as far as in adolescents, trying to get a little more granular, and so that they had a retrospective chart review in 16 hospitals in patients less than 21 years of age. And the diagnosis of COVID vaccine-associated myocarditis, or that CVAM, was based on clinical presentation, abnormal biomarkers like troponin, and or cardiovascular imaging findings that happened within 2 weeks of COVID-19 vaccination. They found 63 cases, 92% were males, so very similar to what the other 2 reports had. And they had all but 1 case presented after the second dose of mRNA vaccine. The good news is that the hospital course was mild. Most of the people didn't even require hospitalization, and there was a very quick recovery and excellent short-term outcomes. Now, these data and some of the other data has led some countries to say what we're going to do is recommend a one-dose vaccine for the adolescents, because we know from that one study that I was showing, the cutout I was showing you, is that even after one dose, you get around a 60% protection. So they're saying we're going to take a middle ground and say we'll give one dose of vaccine because we think the safety is a little bit more. We know we're going to get a little bit less efficacy. Hopefully that recommendation will change. The CDC is still recommended to please give 2 doses of the vaccine to everybody. And this is one of the things I think people need to remember as far as the myocarditis can be caused by the COVID-19 virus, the infection itself. And so in the United States, patients with COVID-19 are nearly 16 times higher risk of myocarditis compared to background rate. And the risk of COVID-19, of myocarditis in COVID-19 infection is nearly 7 times higher, the risk for myocarditis from vaccine. The other thing is that the myocarditis associated with disease is oftentimes much more severe than with the vaccine. So this is another slide then, is looking at the safety of 5 to 11-year-olds, looking at VAERS and VSafe. So VAERS, as I mentioned before, is a vaccine adverse event reporting system, and VSafe is a specific reporting system the CDC set up to collect adverse events for COVID-19 related concerns. And so this was collected between November and December of last year. There were approximately 8.7 million doses of vaccine administered to 5 to 11-year-olds between that time. VAERS received 4,249 reports, and 97.6% of those were not serious. The VSafe, there were 42,500 children that participated in it. This was a self-enrolled and reported symptoms. That there were 57.5% that had local symptoms, and 12,000, so 40% had systemic reactions. And that they found that the reactions were more common after the second dose. Same thing we found in the clinical trials. But the other thing is what they found is that the events from both VAERS and VSafe mirrored identically the adverse events we found in clinical trials. They found nothing else in the 5 to 11-year-olds. And the other thing is that myocarditis has been very rare. In VAERS, they had 11 cases in 8 million doses. So that would be basically 1 per million. And so far, just basically the background rate. And in active hospital surveillance, they had 0 cases in 335,000. So whether this is an event that's in adolescence, whether it's an event related to the higher dose, because remember that 12 and above got 30 micrograms, where the 5 to 11 got 10 micrograms. I don't know. But what I can tell you is that in the 5 to 11, we just have not seen the myocarditis. So then in finishing up a bit is just where are we at with vaccination? So when we first started, we were having a big disparity as far as that in the white population, there was a higher vaccination rate than there was in other racial backgrounds. But this slide is now showing, this is from a couple weeks ago in the CDC, is that the populations, the Asians were higher than any other group, but otherwise you're right around the 80% group, a mark that has had at least 1 dose, and about the 75% that have had 2 doses. The problem with this data, this is lumping the whole United States together, and there's huge geographic variability. And so some parts of the country are 90+%, and others are not that high. And then here is another thing as far as looking at, so instead of looking at race, looking at age. And now this is, I think, shows us where we need to target. If you look at here, 50 and above, is that 91% have had at least 1 dose, and almost 80% have had 2 doses. But if you're going down in age, each decade that you're going down, you're dropping in the percent that have had a vaccine. And then in a 5 to 11-year-olds, we're only at 17% that are being fully vaccinated. The 12 to 17-year-olds, this vaccine's been available for almost 9 months now, and still we're only at 53%. So to me, this is the area where we now want to target here, is that explaining to people why we need to vaccinate. If you remember one of the first slides I showed you, who had the highest incidence? It's not a coincidence that the highest incidence is in the groups that have the lowest vaccine rates. And this is just another slide from the CDC showing that as of July, 42% of adolescents had had one dose. As you saw, it really hasn't changed much since July, so that's very frustrating. But the other thing that they showed is that in the unvaccinated teenagers, they had a 10 times rate of hospitalization compared to vaccinated teens. So this I'm going to try, and Brian, if it doesn't work, maybe you can show it for me, or if we run it, let's see where we're on time. I think we're still okay, to see if it will work and that if you guys can hear it.
COVID-19 is caused by a virus. It can
I think you need to unshare your PowerPoint presentation and change it to the YouTube video.
vaccines to protect us against COVID. The vaccines make an immune response against the spike protein, the part of COVID the virus uses to attach to our cells. When vaccines block the spike protein, the virus can't.
Yeah, we're only seeing your PowerPoint presentation at the moment.
Okay.
Vaccines help make good guys.
What we'll do is we'll just,
If you want, real quick, hold on. I have it pulled up on mine. I can pull it up real quick.
Vaccine is called mRNA, where our body uses the genetic code of the virus to make spike protein. The mRNA goes away in a couple days. Another type of vaccine called adenoviral vector uses a harmless virus to bring the spike gene to our cells.
If you can pause your video, I'll show mine.
Uses the spike protein to make the immune response against COVID. All the vaccines are safe and effective. They don't give you COVID or change DNA. Own methods to create vaccines to protect us against COVID. The vaccines make an immune response against the spike protein, the part of COVID the virus uses to attach to our cells. When vaccines block the spike protein, the virus can't get into our body to make us sick. Several types of vaccines help make good guys, antibodies, which can block COVID spike protein from entering our cells. One type of vaccine is called mRNA, where our body uses the genetic code of the virus to make spike protein. The mRNA goes away in a couple days. Another type of vaccine, called adenoviral vector, uses a harmless virus to bring the spike gene to our cells. Another type of vaccine uses the spike protein to make the immune response against COVID. All the vaccines are safe and effective. They don't give you COVID or change DNA. They don't contain stem cells or affect fertility. We want to get rid of COVID and go back to the way things used to be. So it's important for everyone to get a vaccine against COVID. A message from Cincinnati Children's.
thank you, Brian. And that, sorry, it didn't quite work. I've never quite figured out how to do that, but that, and so we're just about done. I think I had one or two more slides, and if I can get back down to that, then I can show you. But otherwise, the basic thing of this is that, let me see where we're at, is this, is that again, just going through the myths and facts, is that just in interest of time, I won't read all these, but there's a lot of myths on these slides. You guys are welcome to have them and go through this. If this is helpful for you, please use them. One of the things that I've found as far as trying to counteract myths is to try to ask people, what are they afraid of? What have they heard? Who have they heard it from? And may I share some information with you? And trying to be understanding of people's viewpoints and trying to present the data, and hopefully some people, you will change their mind. And that, so as a look to the future, I think we have COVID vaccines have a good safety profile and protection against disease. We now have 3 vaccines that are available through the EUA, the Pfizer, Moderna, and AstraZeneca. Johnson & Johnson, and that 2 more, AstraZeneca and Novovax, have been submitted to the FDA for consideration. The Pfizer vaccine is now available for children 5 years of age and above. Moderna has submitted their data for 12 to 18 to the FDA and is being reviewed. The trials for the children 5 and under are ongoing, and my crystal ball is going to say vaccine for children under 5 is going to be available around late spring of this year. And so these are just last 2 slides of just showing some of our participants and their vaccine cards and being or stickers and being very proud that they got vaccinated. And with that, I'll say thank you very much. So Brian, if there's any questions that I can answer, I'd be happy to try to do that.
So Bob, this is Joe Lopriato. Good to hear you, my friend. Thanks for that presentation. Can you answer a technical question? And that is, when you are doing vaccine trials in age groups like 5 to 11 or 6 months to 5 years, do you
I lost you at the end there where Joe had said, do you stratify? Is that what you're saying? Is that, so the way that we do the, let me see if I can guess what, if I guess what you were saying, as far as that we do each group. So you do the 12, we did the 5 to 11-year-old, and then we got the safety data on the first part of that, and then moved down to the next group, and then moved down to the next group. So we didn't do them at the same time. We did them consecutively, but that once we had data from the group before.
Michael, if you want to go next.
Hi, Bob. Thanks for a great talk. Great information for all of our pediatricians and primary care physicians. A question for you. You know, we have a global population and there are other vaccines in other countries that have been approved. How many of them have been looked at for pediatrics, whether it's the Cyanovac or Sputnik or things such as those?
So the Cyanovac has done some studies in kids. I can tell you that it has not been as immunogenic. I don't have efficacy data. A lot of countries have moved away from Cyanovac because it hasn't proved to be as good as some of the other vaccines. It's not bad. It just hasn't been quite as good. Just to give you an idea, as far as I was showing you those neutralizing titers for the Pfizer and Moderna were close to 1,000. For the Cyanovac, it was around 100. So that we don't know the correlative immunity. So we don't know the exact level of immune response you have to be protected. But at least the assumption would be is that if you have 10 times higher antibody levels, that you're going to be protected for a longer period of time.
Great, thanks.
There's a question in the chat. Any plans to look at vaccine efficacy when administered together with other routine pediatric immunizations?
Yes. I think the first one will be with flu. And that, I'm expecting, that they'll be looked at of these other kind of vaccines. I mean, one of the reasons that we stopped at 6 months, among other things, as far as the lowest level, as far as then you got away from the concomitant administration of vaccines to the 2, 4, 6 months of age. So that was purposeful, is that we didn't want to potentially interfere with the other routinely recommended vaccines. But yes, in the future, I'm sure that at the minimum will be flu and COVID, probably pneumococcus in adults, pneumococcus and COVID too.
Sir, my name is Chase Grooms. I'm a NICU fellow now, but I previously worked as a general pediatrician for a while. One of my great frustrations was always that the vaccine preventable illnesses that your child is most likely to die from, I would say COVID, influenza, and probably cervical cancer, are the ones that the schools do not require. They require rubella and measles and mumps, but they don't require flu, COVID, HPV. Any commentary on barriers to changing that paradigm?
Well, so if you look at what our the schools are requiring, is that they require vaccines for which diseases are easily transmitted within the school. So I'm a big proponent of HPV vaccine. I think it's a very important vaccine. However, if kids are getting HPV in school, we're probably having some other issues that need to get looked at. So that's, I think, why it's hard for the schools to mandate. If you look at what happened in Texas, is that a number of years ago when the governor mandated HPV vaccine, that was the fastest way to shoot down people getting vaccinated. That they say, the government's telling us I have to get vaccinated. What we found has been much more effective for HPV is saying it's a vaccine against cancer. And which one of you don't know somebody that's had cervical cancer? A sister, a mother, a grandmother, somebody. You don't have to go very many degrees of separation. And this vaccine has been incredibly effective there. For COVID, I don't think that there's going to be too much pushback as far as when you have a vaccine that's only authorized, that to say that's going to be mandated. If you have one that's approved, maybe there'll be some traction for mandating. I think part of it at that time is going to be depending on how much disease there is in the community. I mean, my hope is that we're going to get enough people vaccinated, so this is going to at least become more of an endemic virus rather than a pandemic virus, and that the amount of disease is going to go down. As far as flu, I wouldn't be upset if they said that that would be a routine vaccine for schools, but right now it's unfortunately the political atmosphere is not one to try to push that.
Dr. Frenck, this is Pat Hickey. I wonder if you could comment on some of the discussion going on right now about the utility of booster or third doses in an otherwise healthy teenager from both a kind of a public health perspective and a individual health perspective. Thanks.
So thanks, Pat. So, and I think there's a couple points there to bring out is that one is that we have a number of people in our vaccine trial that are calling us, say, give us our antibody responses because we want to know if we're protected. And the answer to that is that I don't know what the antibody levels mean. I can tell you how much antibody you have, but I don't know what it means. So that we don't have what's called a correlative immunity. So like if you look at for Hib or for tetanus or diphtheria, even for flu and that we can say if you get these certain amounts of antibodies that you should be protected against the virus or bacteria. We don't know that for COVID. So the best we can do is really look at epidemiological data is when are you starting to see breakthrough cases and then breakthrough severe disease. And at the 6-month point, that it was still holding well. So that's why the vaccine was really, you weren't seeing many breakthrough infections. You weren't seeing hospitalizations or deaths in the vaccinated. We're now getting further out, so we are starting to see some infections, but as I was showing you, the hospitalizations and deaths, that's not increasing in the vaccine group, it's increasing in the unvaccinated. So the recommendations 6 months after the second dose would be for booster. I don't think it's necessary to get it before then. You may be able to wait a little bit longer than then, but that 6 months is when you're starting to see some change in the infection rate, and that's why recommending the booster. To get it before then, we really don't think that's needed. And then if you remember that data I was showing for the 12 to 17-year-olds is that the immune response was actually 1.76 times higher than it was in the 6 to 25-year-olds. So you could argue the 12 to 15-year-olds could probably even go a year or so before they would need a booster.
There's another question. Any suggestions of how to talk with parents about the efficacy of vaccines to prevent serious sequelae of COVID versus a prior COVID infection? So versus they already actually had the infection.
So unfortunately for this virus, natural immunity is not that great. Is that there's some infections that we know that you just don't get natural immunity. You get malaria, you can get malaria again, you get it again, you get it again. You get syphilis, you can get it again, you can get it again. So that some infections just don't protect that well against repeat infections. Unfortunately, COVID is one of those. There's been small reports where people have been they've had the infection, and then some people have decided to get a vaccine. Some people have decided, I've had my infection, I'm not going to get a vaccine. And they were followed along. This was done by the CDC. And they found about a 3 times increased rate of reinfection in the people that chose not to be vaccinated versus those that chose to be vaccinated. So the vaccines are effective, even in people that have had prior COVID. You still get protection against repeat infection. And that as far as for timing, we're saying if you got COVID, that there's no specific time as far as this. So some people are saying, well, as soon as you're out of quarantine, probably waiting at least a few weeks to a month or two after you had COVID to get a dose of vaccine to let your immune system calm down a little bit before you're then giving the same antigen back to it. I mean, if you look at principles of vaccinology, I mean, that's why we wait the 2 to 4 months between doses of vaccine to give another dose to let our immune system recover a little bit and then give another dose. So in short, I would say, even though you've had COVID, I would still recommend getting the vaccine because the vaccine is better than natural infection as far as preventing another infection. And the timing of it, while you could do it any time, is that if you can wait maybe at least 2 to 4 weeks after recovering from the infection, that's probably best.
All right, and one more question popped up in chat about thoughts about off-label use of the 5 to 10-year-old vaccine for that 2 to 5 year old miss the current surge we have going on? Is this being looked at, or your
So,
thoughts?
so once the FDA has approved a product, is that a physician is able to write off-label. And many of the drugs we use in pediatrics have never officially been tested in children, and so we technically are writing all of them off-label. The thing I get concerned about with the COVID vaccine is that for the dosing is different, and so now we have approved down to 5-year-old. So it gets to be less of a problem. In the 2 to 5-year-old, though, we're using between 3 and 10 micrograms, so that we're testing both of those still, and that so I would be afraid the dose is only 0.2 mLs. The volume is only 0.2 mLs. So then to try to give a fraction of that, I don't think it's possible. So I think that you would either overdose them potentially by giving the full 0.2 mLs, or you underdose them because you're trying to give a fraction of it. So the recommendation of the Academy of Pediatrics and Pediatric Infectious Disease Society is to, and the CDC is to don't write it off label. People can do it, but the recommendation is to not do it. And that, and in the interim, before the vaccine is available, which hopefully it will be in a few months for the 2 to 5 year olds, I think the 6 months to 24 months is going to be more like the end of summer and that. But for the 2 to 5 year olds, masks still work well. And, you know, it's amazing as far as the kids, even 2 and 3 year olds will come in and they have their masks on very proud. They have their nice teeth drawn on their mask, you know, their fangs and that kind of stuff. And that's so they work well, and they don't decrease your PaO2. Although I called my surgeon friends up and I said, now I finally have a reason to know where your brain cells went, is because you were doing too much surgery and that you got hypoxic for too long. It does not affect your PaO2. It doesn't do anything to you. The kids can actually, there's data to show kids can still recognize facial features, expressions, emotions, even though if somebody has a mask on. So people are saying that, you know, it was difficult. Now, if you have a subset of children that have hearing difficulties and they're using facial features, their mouth, that's different. And they actually do have masks where teachers are using where they can see their lips and that, but that's a small segment of the population. And the whole, and we need to accommodate for that, but on the whole, kids do fine. And that a lot of these things are adult projections on the children rather than the children actually having the problems.
Perfect. Well, thank you very much. Have a great day.
All right. Thank you very much, guys. Take care.
Thanks, sir.
Thank you, Bob.
Bye-bye.